Hello everyone. Welcome to today's specialty testing webinar on pediatric autoimmune CNS disorders. This is Amy Ennis, a laboratory technologist resource coordinator for Mayo Clinic Laboratories. Our presenter today is Dr. Andrew McEwen, professor of laboratory medicine and pathology and neurology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function. If you are participating in the audio-only portion of this webinar, following the presentation, phone lines can be unmuted to ask a question. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to our presenter.
Well, thank you very much, Amy, for the introduction, and welcome everybody. Good morning, good afternoon, or good evening, depending on where you are in the world. My job today is to give an overview of autoimmune pediatric central nervous system disorders. I'm not a pediatrician or a pediatric neurologist. My background is internal medicine, adult neurology, and I'm also in clinical laboratory immunology. And I'm director of the neuroimmunology lab here at Mayo Clinic in Rochester, Minnesota. But over the years, I've encountered quite a number of children that I've been asked to see for subspecialty opinions. And we also developed a lot of testing that's pertinent to autoimmune pediatric CNS disease here at Mayo. So I'll start with some just my disclosures here. In relation to some industry support and some patents, and also to bear in mind that any therapies that we might discuss today are off-label. These are rare disorders for the most part. And so here are some acknowledgements of people who I collaborate with as far as Mayo Clinic faculty, consultants who work in our laboratory, also some of our development staff who brought up and developed some of our tests, and then also some other people who lead our clinical laboratory and our study coordinators, admin support, and some of our funding as well. So the objectives of this talk are to recognize the key clinical features of pediatric autoimmune CNS disorders, to try to give you a framework for evaluating suspected cases, and then also a little bit about treatment. So neurological disorders in general that are caused by autoimmunity are worth discussing just in very general terms initially. And so I'll give a little bit of background about that before delving into some of the more specific pediatric disorders. So what are autoimmune neurological disorders? Well, these are disorders where the immune system is targeting the nervous system and causing inflammation and dysfunction. Obviously, there are kind of a number of very common autoimmune disorders that we're all familiar with, such as type 1 diabetes or thyroid disease or rheumatoid arthritis. So essentially what we're doing here in this situation is discussing cases and discussing the whole field of patients that have an antigen-specific immune response, so where there's a nervous system protein or multiple different proteins that are being targeted by the immune system, and we can pick up these fairly robust biomarkers, antibodies against these proteins in the serum or the spinal fluid of these patients. So conceptually, these are disorders that are beyond our traditional concepts of central nervous system inflammation, such as multiple sclerosis or sarcoidosis, where there are certain clinical, radiological, pathological characteristics that define these disorders, but where there's no specific autoimmune response against a specific antigen. So these disorders traditionally have been thought of as being rare disorders, but over time it's been recognized that these are actually more common. Some of this has been contributed to by an increased awareness of these disorders, which in turn I think has been contributed to some extent by the availability of disease-specific biomarkers and recognizing clinical phenotypes. So the antibodies themselves can be detected in serum, CSF, or both, and that largely depends on the disorder and the clinical phenotype that is in question as to whether it's appropriate to order serum or CSF or both. So how do these patients present? Well, the typical presentation is that of rapid onset and progression over a course of days to weeks, usually up to about 3 months, with week-on-week progression. Sometimes a fluctuating course, sometimes even spontaneous remissions with further relapses afterwards. This can affect any domain of the nervous system. These can be monophasic disorders or relapsing disorders. There are some classic phenotypes, such as in pediatric disorders, such if we took an example of, say, neuromyelitis optica, that would be kind of a classic autoimmune phenotype. Patients, though, can have atypical presentations as well. So, for example, you could have a patient with NMO that might just present with a brainstem syndrome. Another example in children that is worth pointing out is that sometimes the presentations, if you're coming from the adult perspective, you might be mistaken and think in not thinking about the symptoms that are germane to a child. And so, for example, in NMDA receptor encephalitis, in adults we typically think of anxiety, depression as presenting symptoms, but that may manifest as behavior change in a young child. And of course, these disorders are not always kind of the classical neurological phenotype associated with a particular antibody. There can be multifocal disorders that exist also. So, going through the nervous system then from top to bottom, it's recognized that there are encephalitides, more restricted disorders like autoimmune epilepsy, optic neuritis, optic chiasmitis. In adults, we think about retinopathies also, basal ganglia for movement disorders. So that could be chorea or other hyperkinetic movement disorders. And some of these are well described clinically, at least, in the literature, such as chorea, some tic disorders, which can be post-infectious. Then there are a number of other disorders affecting the cerebellum, and inflammatory cerebellitis or autoimmune cerebellitis is recognized in children already. Some of these disorders have antibody biomarkers, others do not have reliable antibody biomarkers. These disorders can affect also the brainstem, and sometimes there's an overlap between cerebellum and brainstem in terms of presentations. You can then have spinal cord disorders, particularly in children, myelitis, rather than paraneoplastic myelopathies, which we don't tend to see in children. And then peripheral nervous system disorders or myeloneuropathies. A lot of the radiculopathic disorders are more what we would see in paraneoplastic disorders in adults. And also sensory neuronopathies is something more we would see in adults. There are some disorders in adults that can mimic anterior horn cell disorders, but they don't have that classical presentation. Neuropathies, myopathies, necrotizing autoimmune myositis in adults is an example of an autoimmune myopathy. And then the neuromuscular junction disorders, which are pertinent to children, myasthenia gravis and occasionally Lambert-Eaton syndrome. But I'm going to focus on the central nervous system today. And so here are some examples of kind of classical disorders that are pretty well recognized, such as limbic encephalitis, autoimmune chorea, which can occur in, say, lupus or antiphospholipid syndrome, or indeed we can see some dyskinetic movements that are chorea-like but not classical chorea in NMDA receptor encephalitis, cerebellar degeneration, brainstem encephalitis. In terms of cortical brainstem type disorders in children, a classical is the opsoclonus myoclonus syndrome, which we'll come back to, myelitis, and then also the stiff person syndrome and variants of that. So examples of disorders that, in terms of variants, a limited form of limbic encephalitis could be epilepsy. So you could have a patient who would present just with seizures of temporal lobe type. That may evolve into having other features, but it's quite possible that the patient may just present clinically with seizures. Then there are patients who have a more widespread variant of the classical rather than a more limited one. An example of this would be progressive encephalomyelitis with rigidity and myoclonus, which is essentially a stiff person type phenotype, but with that superimposed autonomic and encephalitic features. So what are the risk factors for these disorders? Well, in some patients, there can be some risk factors such as coexisting autoimmune diseases that pre-exist the onset of the neurologic disease or are discovered at the same time. But in children, that's less frequently the case, even for some of these disorders such as neuromyelitis optica and so forth, because particularly in very young children, because essentially there just have been a few years of life before the onset of the neurological problem. And then there are other disorders where it's just typically not seen. So NMDA receptor encephalitis, for instance, we don't typically see a strong autoimmune history. There can be some instances where a neoplasm might be relevant. The two that come to mind in children would be teratoma and NMDA receptor encephalitis, and the other would be neuroblastoma, and perhaps one anti-Hu autoimmunity. Sometimes family history can be a clue. But the reason to kind of think about these is not just, okay, if the patient has this, I'm going to order a test. It's more like we're trying to build a profile here of what are the clinical clues in terms of the neurological aspects of things, the subacute onset and rapid progression, all those things I went through. But then secondly, is there anything immunologic in the background that may explain or is a clue to what's going on. So beyond history then, the next stage is really trying to establish objectively what's going on with the patient in terms of the neurological exam and some paraclinical testing. These are important not only to help make the diagnosis, but also to permit us to have a baseline against which we can treat, and then do some follow-up testing in the abnormal tests to demonstrate improvement. A lot of people have neuropsychiatric symptoms for the better or for worse with corticosteroids, and that's true of patients who have had steroids for any reason, not just treating autoimmune encephalitis. And so those subjective type changes need to be interpreted well. And having some objective data is helpful in that situation. So how do we evaluate further? Well, in terms of the immunological aspects of evaluating further, when it comes to testing, there's antibody testing, which can be some of the non-neural antibodies to really try and build that picture, because not all patients are going to have nervous system directed antibodies detected. And so these more generic biomarkers of autoimmunity just in the background can be helpful, but they're also fairly common in the general population, so need to be interpreted with caution. In the CSF, you can have more inflammation-specific factors detected, like elevated white cell count, IgG index and synthesis rate, and positive oligoclonal bands. And then neural antibodies can be detected in serum or spinal fluid, and we're going to focus a little bit more on that today. So what about the antibodies themselves, and what do these represent from a diagnostic perspective, but also from a pathophysiologic perspective? So although I mentioned we don't commonly see tumors in pediatric cases, I'm going to use this as the paradigm here of an immune response against a nervous system expressed protein or antigen in a tumor, and then you have an immune response that's appropriate to be developed against that tumour and or against the protein in that tumour. And so basically you'd have antigen presenting cells sending the signal to T helper cells, and then the development of antigen specific cytotoxic T cells. And then antibodies are generated after the B cells become involved, and then you have those differentiating into plasmablasts, plasma cells, and antibody production. Now on the right side here in the green, what I'm demonstrating here is the antibodies are generated, but they're not thought to be disease causing, and so this will be a situation whereby the antigen against which this immune response is generated is essentially processed in the proteasome, degraded. You have linear polypeptides expressed in MHC class 1 that these cytotoxic T cells can recognize, and that leads to nervous system destruction. It leads to destruction in the tumor, but then in the nervous system it can lead to neuronal damage and death. But you still have antibodies generated, but these may have some effects, but they're not thought to be pathogenic in the disease itself. But nonetheless, these are good biomarkers in the lab. So an example of this would be anti-HU or ANA1 or GFAP antibody. The second group then is where there's the same process and the same players, but in this scenario, the protein of interest or the antigen of interest is a cell surface protein such as a receptor, water channel, ion channel, where the extracellular domain is expressed in its 3D conformational state. And so you have these conformational epitopes against which you have an immune response, and these antibodies have pathogenic effects, potentially. So an example of this would be NMDA receptor encephalitis, where you get this binding of antibody and cross-linking, and then internalization, and loss of function as a result. But with removal of the antibody over time, these receptors can come back and you can get restoration of function. Another thing that can occur is you get, after antibody binding, you can get activation of complement, and then downstream of the initiation of the classical complement cascade, you can get tissue inflammation and tissue destruction as a result of that inflammation. And an example of that would be aquaporin 4 autoimmunity or neuromyelitis optica. So that's the paradigm of paraneoplastic, but there can be other ways that this type of autoimmunity can develop. So an example here is a patient with herpes simplex virus infection. You can see fairly typical MRI findings in the temporal lobes, bilaterally, in limbic regions, and also in neocortical regions, and in the insula. And this particular patient had improvements with antiviral therapy, but subsequently relapsed. And in the heretofore it was thought that these patients were having an actual relapse of viral infection, but as it turns out, these are HSV PCR negative at follow-up when they come back with their second event. But what's actually happening is they've developed NMDA receptor autoimmunity as the second wave of that. And you can see if you look at H here, the staining of the hippocampus here, mouse hippocampus stained with patient IgG. And then also you can see that these live hippocampal neurons are stained with patient IgG also, and then also these NR1 or GLUN1 subunit expressing cells are also have patient IgG bound to the cell surface. So that's an example of a post-infectious autoimmune disorder. But in reality, for most patients that we see, and particularly in children actually, we don't know why this develops. There isn't necessarily a clear genetic background predisposing to autoimmunity that we can see, or there's no cancer detected, or there's no premorbid infectious symptoms. So going on then to talk about it in a little bit more slimmed down version. So we have our antibodies against cell surface antigens. We have our neuronal, nuclear, and cytoplasmic antigens. They both have antibodies that are generated as part of the immune response that are excellent biomarkers or have that potential in the clinical lab. And these antibodies can give us information, not just for the specific diagnosis, but in very general terms, the ones in red, these ones like NMDA receptor antibodies, glycine receptor antibodies, tend to be more immunotherapy responsive, whereas the classical paraneoplastic disorders like ANA1 or anti-HU being relevant to children, a lot of the time immunotherapy is not particularly helpful, but that's not to say we don't try those treatments, because there can be other mitigating and unseen and undetected components of the immune repertoire at play that we're not aware of. There could be important factors here, and so as a result, we don't just rely on the biomarker and sort of say, well, we're just going to kind of give up in this situation. We would typically treat these patients pretty aggressively, but the outcomes aren't always that great. So to kind of discuss it a little bit further as far as the cancer associations, I've highlighted in green here the ones that are pertinent to children, but just these are the kind of the list of antibodies that are encountered in children. Now, some of them are more commonly encountered in children, like MOG antibody, NMDA receptor antibody, and then there are others that are less commonly detected but are still important biomarkers like GABA-A receptor autoimmunity. And then there are some that are, quite frankly, vanishingly rare but can occur depending on the circumstance. And so this would include things like DPPX antibody, TCATR, and GLUR1. There have been children reported with these. So how are antibodies detected? Well, they're detected by in our lab by indirect immunofluorescence assay. I showed you an example from a paper earlier there when we were talking about post-HSV. But in the lab, we can screen for most antibodies, actually, by this particular method, which is applying to a composite of mouse brain tissue, also with some kidney and gut as control, looking for IgG binding to hippocampus, cortex, basal ganglia, and thalamus, and then not binding to kidney, which excludes the possibility of a sort of a non-organ specific antibody. And then this can be confirmed by doing a number of different tests depending on the particular antigen of interest. So in this particular situation would be a cell-based assay to confirm this is NMDA receptor antibody. So with each antibody then we can generate immunohistochemical diagnostic criteria that allow us to identify the antibody and then reflex it for confirmatory response or confirmatory purposes and to generate a report. This is also the bedrock of a lot of our discovery as well, because we see patients on a pretty regular basis whereby there is staining of nervous system tissue but with patient antibody, but we don't actually see any recognized features that would say, okay, this is NMDA receptor antibody or something else. All we know is that it's brain specific. But after some time, then we generally would accumulate some cases with the same staining pattern, similar clinical features, or maybe a tumor in common that would allow us then to go and proceed to antibody discovery. So other methods then for screening in the lab would include cell-based assay screening for some analytes or immunoprecipitation assay screening in some circumstances too. So here's an example of a cell-based assay where you have 293 cells expressing the protein of interest, and this is GFP tagged, green fluorescent protein tagged. But then we apply the patient serum, and you can see that it co-localizes here. So there's IgG binding to the cell surface, and it's basically binding to the GFP tagged aquaporin 4 on the cell surface. So this is the principle involved, but in reality, a lot of these are either ones that we've, for some disorders, developed in-house, or others they're available as kind of composite kits, whereby you would have several antigens in one well that are of interest. And so largely it's those red antibodies I showed you earlier that we use the cell-based immunofluorescence in. And then we can do flow cytometry also as just a non-observer based method for detecting antibodies. And so here you've got FACS or flow cytometry, whereby we're actually counting the number of cells that are expressing the antigen of interest, in this situation GFP tagged aquaporin 4 again. And so by measuring the amount of cells that have patient antibody bound, and measuring the signal from the secondary antibody fluorophore, we can determine the number of cells that are positive for aquaporin 4 versus a population of cells that aren't even expressing the protein. And so this gives us a ratio, and then that's something we can report out. So the advantage of that is that basically for efficiency in the laboratory, it means that we can test a number of patients at one time without requiring a technologist to read the assay, and we get a readout from the flow cytometer. So for the more linear epitope proteins, where we're talking about kind of an immune response against this protein of interest that's expressed in MHC class 1, associated with things like small cell lung cancer in adults or neuroblastoma in children, these types of classical paraneoplastic antibodies are best detected by Western blot. And here are some examples of different blots that we've used in our own lab over time, and some more modern commercial multi-antigen type strips, immunoblot strips. For some of these analytes, then we also, for ones that we've discovered in our own lab, like the neuronal intermediate filament antibodies or GFAP, we also use a CBA. So far we've talked about what these patients look like in general terms, the pathophysiology behind some of these disorders, what detecting an antibody could mean in terms of either the pathophysiology of the disorder, but also as a clinical biomarker. And then we've also talked a little bit about the methodologies. So moving on then to the disorders themselves, I would start to talk a little bit about autoimmune encephalitis. And so it's been recognized that the incidence and prevalence of these disorders of autoimmune encephalitis are increasing over time. And this is largely down to improved recognition. But it's now at a point whereby these disorders have this equivalent incidence and prevalence to infectious encephalitis. But a lot of these patients are still, their disorders are still poorly characterized, so up to half of children, or maybe a bit more, who have had autoimmune encephalitis diagnosed in the United Kingdom in a tertiary referral centre are seronegative. And as you can see, if you kind of look at the different presentations that the patient have, despite everything that we might read about kind of very specific things associated with different phenotypes, you can see that there's really not a lot of difference between the two groups, whether you're seropositive or seronegative. And so sometimes we can maybe be a little bit blindsided by the literature insofar as we think, okay, well, if a patient presents in certain X way, well then it must be Y disorder and it couldn't be anything else. It turns out that generally isn't applicable for some things where it's absolutely classical. Sometimes you're going to get it right, but there are also occasions where you're going to get it wrong. So that might be okay in genetic disease in terms of how you might approach testing, but for something where really time is brain, not in the same way as stroke, of course, but where days and weeks really matter, trying to make a clear diagnosis to bring about the best possible outcome, it is important to think about profile-based testing rather than standalone individual antibody testing. Now, that profile could be very large or very small. And so, for example, optic neuritis, you could have 2 antibodies that would be pertinent, MOG and aquaporin 4. And for encephalitis, though, it could be many different antibodies. And so on, I've shown you a list of those earlier, and we'll go through all of those. But also, the specimen type selected might vary. So for optic neuritis, again, you might just need to send serum for MOG and aquaporin 4 antibodies. Whereas for autoimmune encephalitis, you might be thinking, okay, I actually might need to get serum and CSF sent off in these patients simply because of the broad possibilities, the sheer number of biomarkers involved, the differences in terms of sensitivity and specificity of different specimens, so NMDA receptor antibody more sensitively and specifically detected in CSF, and other antibodies such as MOG antibody being more sensitively detected in the serum. So this is MOG autoimmunity, and many of you will have seen MOG IgG positive patients, or will at least have seen the phenotypes, and so these are patients typically with relapsic or monophasic optic neuritis or myelitis. MOG autoimmunity, myelin oligodendrocyte glycoprotein autoimmunity, is also, it would appear, to be associated with a large proportion of childhood ADEM or acute disseminated encephalomyelitis. There are some unusual brainstem disorders, also some patients with a unifocal or unihemispheric epilepsy type disorder. I'm not sure if that's been reported in children, but certainly it has been in adults. Neuromyelitis optica type manifestation, where you could have optic neuritis initially and then myelitis as a second attack. But as you can see here from this particular study that I'm showing here, the breakdown is MOG autoimmunity between adults and children. You can see how prominent the ADEM is in children but not in adults. You can see how optic neuritis is really the very prominent phenotype in these patients, including bilateral optic neuritis, recurrent optic neuritis, isolated one-event optic neuritis. And the other thing that we can see in these patients is how steroid responsive that these children are, and very often that with the optic neuritis it can be quite a severe vision loss, but with full recovery of vision and no optic atrophy afterwards. But on the other hand, a lot of them are very steroid dependent, and it's not entirely clear at this point what is the best strategy to manage these relapsing cases. The reason being that very often there can be more than 2 attacks, and patients can just relapse and relapse again with corticosteroid treatment, and sometimes low-dose prednisone as maintenance might be an option. There is some data to suggest that maybe IVIG is useful in these patients, particularly if we're getting into a bad steroid-dependent situation. But some of the standard treatments that have been used over time to treat, say, neuromyelitis optica, the benefits seem to be kind of patchy. So there are some that seem to respond and others not so much. So aquaporin 4 autoimmunity has a similar clinical phenotype in terms of the types of neurological presentations, but in many respects that's where the similarities end. The big differences with aquaporin 4 autoimmunity is the very high predisposition for relapsing course, and also the severity of the attacks in terms of neurological outcome from an untreated attack or from accumulated disability from stepwise repeated attacks. So this is one whereby we can say for sure that the antibody is not only telling us the diagnosis, but is also telling us exactly what we need to do with treatment, which is long-term immunosuppression. So the types of presentations patients can have, and this is from our paper in 2008 where we looked at all of the phenotypes and other features of patients with aquaporin 4 autoimmunity or pediatric neuromyelitis optica. And these accounted for about 5% of all aquaporin 4 autoimmune patients. So you can see some of the features here, and one of the often the early clue to this can be brainstem symptoms such as vomiting due to area postrema involvement, intractable vomiting, nausea and hiccups. There can be other perithird ventricular type disorders such as SIADH. The common manifestations again are transverse myelitis and optic neuritis, as the name suggests, but kind of a relapsing course. You know, it would be less common to see both optic neuritis and transverse myelitis occurring at the same time. But one of the key standout things in children is the amount of brain involvement, and so 45% of children will have brain symptom involvement at one point, and not just radiological involvement. So we're used to seeing some radiological involvement in adults, such as these perithird ventricular lesions, but typically in children these are accompanied by clinical symptoms also. And here you can see a longitudinally extensive T2 signal abnormality in the cord, which is very classical for NMO, but also you can see that it's coming up into the medullary region as well, and that's often where it hits the area postrema chemoreceptor trigger zone and causing nausea and vomiting. Here are some other features that can be seen in the cerebral hemispheres in these patients. So you can see these kind of radial, almost tentacle-like pattern of periventricular enhancement. You can see these ADEM-like lesions, and often these, before the existence of aquaporin 4 antibody, these kids would have been diagnosed with ADEM initially, but then when there was a recurrence, then it was, okay, is this recurrent ADEM or is this a severe form of MS? But as you can kind of see over time, you know, there is unfortunately some damage, some atrophy and so forth that can occur as a result of these repeated attacks of inflammation. So very important that these patients are diagnosed expeditiously and treated. Unlike MOG autoimmunity, where we don't actually see a loss of coexisting autoimmune disease, it is actually pretty common for us to see pre-existing autoimmune disorders even in children, such as the ones listed here. Also, as distinct from MOG autoimmunity, we very commonly see autoantibodies against various connective tissue disease related antigens, and then other non-neural, or sorry, other neural antibodies as well. So these patients tend to be kind of teeming with autoimmunity. But if these patients, you know, are having recurrent attacks, there's very bad morbidity with this disease, and also some mortality, unfortunately. So these numbers come from 12 years ago, and it's quite possible that this would look different now insofar as outcomes. Because at this stage it's recognized that, okay, if the patient's aquaporin 4 antibody positive, they need to go on immunosuppression, and if that doesn't work out, then they need to change to a different immunosuppressant. And so I mentioned earlier the role of complements in this disorder. I'd also mentioned at the very first or second slide that the treatments for autoimmune CNS, pediatric CNS disorders are off-label. That's actually not entirely true. There have been a couple of drugs that have been approved at this point. One being eculizumab, which is targeting the C5 complement component and actually prevents the complement cascade going to its pro-inflammatory and destructive conclusion. And as a result, in a randomized controlled trial, this drug was shown to be very effective for preventing relapses. So that's an example of how you can go from a disorder that's very devastating to one that's potentially very treatable, but purely down to understanding the underlying pathobiology. So NMDA receptor encephalitis, and these are, we mentioned earlier, kind of some of the behavioral changes that can be seen in children, but other features that often developed in a stereotyped kind of stepwise course can include seizures, encephalopathy, dyskinesias, dysautonomia with marked fluctuations in blood pressure and heart rate, hyperventilation and coma. About half of the patients overall have ovarian teratoma, but this is pretty uncommon in children. The peak for ovarian teratoma is somewhere around the age of 30. As I mentioned, CSF testing is absolutely vital in this situation. Serum testing alone will not cut it. And then typically these patients need a lot of treatment, immunotherapy, but notwithstanding that, patients are often very sick for many months and require a lot of support, often in ICU for prolonged periods. So here's an example of kind of some of the dyskinesias that you can see. So this is a kind of a relatively mild case, but it's important to kind of be able to see these things and to pick them up. You know, it's not as kind of dramatic as some of the other videos that you might have seen in NMDA receptor encephalitis, but where the dyskinesias have been involving the head and neck and extremities also. So we mentioned earlier about autoimmune epilepsy and how some patients, rather than presenting with a full-blown encephalitic presentation, can present with just seizures. And there are various autoantibodies that are pertinent in this situation. For the children, one of the ones we think about are LGI1, GAD65 antibody, GABA-A receptor antibody, in addition to NMDA receptor antibody, MOG or aquaporin-4 autoimmunity. And sometimes the radiology can be helpful. So in this particular situation, you can see these multifocal, multilobar, large-ish, medium-sized, I guess, T2 signal abnormalities, but without contrast enhancement. And that's very typical of GABA-A receptor autoimmunity, where the patient can present with seizure-predominant encephalitis, or indeed seizure-isolated presentation as well. And this is, again, is very immunotherapy responsive, so an important one to recognize. So moving on to one that we described here at Mayo Clinic, which is this inflammatory meningoencephalitis or meningoencephalomyelitis. This has largely been described in adults. We have encountered several children with this over time, but the clinical presentation really doesn't differ overall, or the radiological findings don't tend to differ either. So the big hallmarks clinically are these features, but also very inflammatory CSF with a lymphocytic white cell count usually in the hundreds. They can occasionally be associated with teratoma, generally with coexisting NMDA receptor antibody, and generally steroid responsive, but also unfortunately steroid dependent. About a quarter of the patients have a relapsing course. So here's some of the typical radiology findings. So the patients often present with things like headache, blurred vision, tremulousness, and then kind of multimodal type encephalopathy, often with some neuropsychiatric symptoms at onset, as well as delirium and memory changes. And as you can see here, the post-gadolinium sequences are quite telling. This particular feature is not pathognomonic of this disorder, but it is quite characteristic, where you have this periventricular linear gadolinium enhancement, which is actually in GFAP, or glial fibrillary acidic protein enriched regions of the brain. And you can see this across a few patients here. But then also we can see some other abnormalities, such as leptomeningeal type enhancement or serpiginous enhancement, as you can see in this case here. In the spinal cord, we don't tend to see outright myelitis clinically in these patients, but they can have signal abnormalities that look quite like NMO. I tend to see these generally as being more kind of hazy T2 signal abnormality, rather than something very kind of stand out on the T2. But you can also see this linear pattern of enhancement along the central canal in the spinal cord, which again is in an aquaporin 4 enriched region. You can also see similar radial changes in the cerebellum, and this is to remind me that optic disc edema can be seen in these patients. So they have a normal opening CSF pressure, don't have hemorrhages or exudates, they don't have painful vision loss, but they can have some blurred vision with this optic disc edema. So as far as the particular antibody is detected, again, we do this by indirect immunofluorescence assay, and there are strict diagnostic criteria that we have for that. And you can see some of these features here, and you can kind of see how, around the ventricle, this sort of filamentous staining, and it somewhat resembles the periventricular enhancement we actually see on the MRI scans of the patients. There were some clues to why this might be GFAP in the first place, including that particular staining pattern that resembled what we'd seen in the literature. But also there were some animal models and an actual disease in dogs that resembled the human disease also. We confirmed this then by cell-based assays. We get reactivity against different GFAP isoforms. As it turns out, the GFAP alpha, the fully adult form of GFAP, fully mature form of GFAP, is the one that's most sensitive and specific for the clinical diagnosis. So that's what we use in the lab, is the cell-based assay to confirm those cases. As well as being steroid responsive, though, as I mentioned, these can be steroid dependent. And you can see a sequence of events in a patient here with T2 flare on the top and post-GAD T1 on the bottom. And you can see this kind of relapsing course as we go through A1, A3, and then to A5. But then typically at these patients, if we do a slow steroid taper and add an oral immunosuppressant such as mycophenolate, we tend to get a longer term remission. Moving on to LGI1 and Caspr2 autoimmunity, this is again less common in children. Here's our Mayo series with 11 patients, 13 patients here. And as you can see, that there are a number of different features that are in common with the adult presentations, such as encephalopathy, limbic encephalitis, sleep disturbances, and neuropathic pain and cramps that are kind of more characteristic of, I guess, of Caspr2 in adults, but we can see it across the board in children with LGI1 or Caspr2. One of the things that stands out, though, is how facial brachial dystonic seizures are, at least in our series, was not encountered, which is one of the classical presentations in adults with the disorder. As you can see here in the brain stem of a child, there's an inflammatory lesion here. You can also see typical limbic encephalitic change. And then sometimes there can be myeloradiculopathic changes on imaging as well. The stiff person syndrome, as mentioned earlier, this can have various phenotypes: classical, stiff limb, more extensive stiff trunk, or PERM, progressive encephalomyelitis of rigidity and myoclonus. And just wanted to kind of review a few of the features, and so you can kind of see the different phenotypes here. There's some autoimmune disease in the background. Typically speaking, these are the patients with the GAD autoimmunity, so the ones that have type 1 diabetes, thyroid autoimmunity, and so forth. And here are the GAD values in those patients. There can be some patients also, though, who are glycine receptor antibody positive, which can sometimes give us some increased sensitivity for an overall diagnosis. But also, if you have glycine receptor antibody positivity, with or without GAD antibody, it seems to predict a more likely immune therapy response. So the treatments involved are both neurochemicals directed at the GABA deficiency or brainstem spinal hyperexcitability, such as diazepam, baclofen, but then various immunotherapies are useful for this disorder too. IVIG is the one that has the best data behind it, insofar as there was an actual randomized controlled trial done on this about 20 years ago. So you can see that there are kind of varying kind of outcomes in these patients as well, but mostly seem to do quite well. The glycine receptor autoimmunity is one that has been recognized in more recent years. Initially, it was associated with very severe disorder, PERM, which is very widespread and can be fatal. But we have encountered in adults and children more focal phenotypes. This particular child presented with spasms in his low back, and you can see the exaggerated lordosis. You can see the tautness of his extensor paraspinal muscles as he walks. Unfortunately, he's had quite a rocky course as far as treatment. Initially very responsive to plasma exchange, rituximab, but in more recent times has been more challenging to treat. So this particular antibody, though, can have some false positivity in the serum. So well, when I say false positivity, I mean we see results that we're not sure exactly what the importance of it is, and even in healthy controls we can see this. So as a result, when this test will go live, it's not incorporated into any evaluation right now. We're actually not going to offer it as an evaluation, but it'll be a single orderable test, and really we'd recommend it at the moment for patients where there's suspected stiff person spectrum disease. But we can clean up things a little bit, but this isn't really something practical that we can do. But using a live cell assay, we were able to demonstrate that the true patients had, at 4 degrees, if you applied the serum to glycine receptor expressing cells, the serum doesn't do anything because you're at 4 degrees, but when you go to physiologic conditions at 37 degrees, you get internalization of the antigen off the cell surface. Similarly, then we did the same thing looking at comparing a patient at 37 degrees. You see the antigens largely gone off the cell surface again, but then a seronegative healthy control, we saw some binding, but didn't see any internalization, and similarly with a false positive control, where we had a glycine receptor positive patient, but didn't have any stiff person-like disease. We saw the binding to the cell surface, but we did not see any physiologic activity of that antibody in terms of its ability to bring receptor off the cell surface. So sometimes these functional assays can give you some additional information, and so we know that already for, say, myasthenia gravis, where you have both binding antibody and also modulating antibody. Now, paraneoplastic disorders, so this is ANA1 or anti-Hu, and here you can see there are kind of a variety of different presentations, including opsoclonus myoclonus syndrome accompanying neuroblastoma, and then there can be limbic encephalitides where no cancer is found. The treatment is often directed at the cancer or at trying to suppress T cells. Diagnosis for cancer in general in children is, there are not necessarily a lot of diagnostics we have to do, but for suspected neuroblastoma, these are some of the tests, and then for teratoma, MRI of pelvis is typically done in young children, and then pelvic ultrasound with transvaginal views in adults onwards. So for opsoclonus myoclonus syndrome, in addition to the neuroblastoma and a association, there are a lot of children who have an idiopathic form of the disorder, and that leads to this syndrome, which I'll show you now. This isn't a child, this is an adult, but it's the video that I have. But just for recognition purposes, this is a patient here who has these lightning-like myoclonic movements, multidirectional. That's very characteristic of what's called opsoclonus, so essentially myoclonus of the extraocular muscles. And then you can see the diffuse tremulousness in the limbs leading to balance problems. And children, that can also manifest as behavioural disturbance as well, or poor academic achievement later on in childhood. But again, it tends to be very often immunotherapy responsive, typically corticosteroids or ACTH plus IVIG and rituximab. Rarer IgG occurrences in children can include the mGlu-R1 antibody, which is associated with ataxia, DPPX antibody, which can be associated with a PERM, progressive encephalomyelitis with rigidity and myoclonus type phenotype, but can have a variety of different encephalomyelitic symptoms. We don't see cancer in those patients. And then some virtually unheard of IgG occurrences in children, such as this one isolated case of PCA1 autoimmunity. So for some where there are a few patients reported in the literature, we do offer the particular tests such as DPPX in children, but in one case that I've personally reported of PCA1 in a child, I think it's of questionable value to have that in an evaluation for children overall. Notwithstanding that, if we did happen to get an evaluation in for autoimmune CNS pediatric disorders and we did see PCA1, we'd certainly be able to report that out, but we'd probably have to generate a separate order for it. But similarly, there are other things like CRIM5 IgG, ANA2, which is anti-Re, which we've not encountered in children, and thus don't offer it as part of the evaluations. So for these, this is kind of just an overall treatment algorithm. So doing trials of treatment sometimes, particularly in children where it's not entirely clear, is it autoimmune, you might still do a trial of treatment to try and see if you can get improvement from steroids or IVIG or plasma exchange. And then if there isn't improvement, considering one of the other ones you haven't tried, and then if there is improvement, considering maybe a medium-term slow taper of whatever treatment worked, or maybe switching to an oral treatment, and for relapsing patients, considering maybe a longer-term immune suppressant. And then, as mentioned earlier, we're now kind of in the era of monoclonal antibodies, and having better understanding of some of these disorders and their pathophysiology, there are particular molecules that can be specifically targeted, such as C5 or CD19. And so these are treatable disorders, more often than not, usually non-paraneoplastic. Some but not all adult type disorders are pertinent in the pediatric space. Serum suffices for some disorders, but we need serum and CSF testing for other phenotypes to get to that diagnosis quickly. And then positivity assists in the diagnosis confirmation, but also can sometimes assist in, okay, for say common disorder like MOG or NMDA receptor autoimmunity, there is some literature out there that's going to give us some guidance as to what to do. For aquaportin 4, there's good studies in terms of what drugs are likely to be effective for relapse prevention. And then also sometimes prognostication. So we can derive some prognostic information or what's likely to happen in a child with a particular autoantibody. But bear in mind, up to 50% may be seronegative, and sometimes we just need to build that picture from clinical principles, some ancillary testing, and then maybe even a trial of treatment. So I'd be happy to take questions. I'm sorry, I went a bit long there, but if there's anything that you don't have time to ask now, feel free to drop me a line by email. Also, a number of these things that we do, like glycine receptor antibody, we are only offering on a research basis at the current time. Same with GABA-A receptor antibody. We only do it on a research basis right now, but plan to offer these clinically in coming times. But you can always contact me if that's something you're interested in testing for. Thank you.
Thank you, Dr. McEwen. At this time, we would like to take any questions that you may have. If you would like to ask a question, please submit through the chat function on the CenturyLink web application. For participants joining in the audio-only portion of this webinar, press *7 to unmute your phone. Once you have finished asking your question, press *6 to mute your line again. And we do have a question already posted. Can you comment on sensitivity and specificity of CVAs for MOG, in particular comparison to other antibodies such as NMO?
Yeah, sure. So I think for the common kind of commercial kits that are generally used in labs, the aquaporin 4 sensitivity specificity seems to be pretty good and seems to closely approximate what's been reported from various academic labs, such as ourselves in Oxford University. The MOG less so, is my understanding, that has been published. If you look at papers by Waters, Komorowski, and Piddock, there was a multi-institutional comparison of different MOG assays, and there seems to be better specificity with some of the ones that have been done as academic labs like ourselves in Oxford. However, with any lab with MOG antibody, and no matter what platform people are using, there is an issue with low positives, and we're kind of encountering this in some patients with more classical multiple sclerosis who kind of have a low antibody titer, and the more classic MOG phenotypes occurring with higher titers.
What do you do in a child with suspected autoimmune encephalitis and negative testing, including oligoclonal bands, IgG index, neoperotin, microglobulin, MATA, TPOTG antibodies, and mild improvement on IV steroids and IVIG? Would you consider another agent?
Yeah, I think that's challenging. But it's the and I've always actually found the most challenging group, and that's probably because of my lack of formal training in the area, but I've also often found discerning true objective improvements in children quite difficult with immunotherapies, particularly steroids, because steroids can have all kinds of neurochemical sort of off immunologic target type effects, and I think it's quite challenging. I mean, I think that if there's some supportive evidence, that this is not just kind of based on, essentially the presenting complaint of behavioral disturbance or cognitive disturbance. There is some documented kind of findings in the MRI or on the EEG or something like that, then I think it may be worth considering that. But it's quite challenging, and a lot of the time it's parents will want treatment done, and in my experience, sometimes there's a lot of focus on this is an autoimmune diagnosis, and we're sure that this is something autoimmune from a family standpoint, because if it isn't autoimmune, the alternatives are quite psychologically devastating to deal with, because there's an anticipation based on kind of what's in the media and so forth, that patients with autoimmune encephalitis respond, and that they'll get better and those kind of behavior problems will go away. So I find it quite a challenging area, to be honest with you.
What is your perspective on pandas?
It's a type of bear. Yeah, I don't, I think that within pandas, I think that there are definitely patients who have had, some kind of post-infectious tic disorder or other movement disorder or encephalopathy or both, sometimes with neuropsychiatric manifestations, chorea. I have seen a couple of kids like that, but more often than not, the patients I've been asked to see with this are people with other problems who happen to have a positive anti-streptolizin O test, and potentially have had some, say, testing from some laboratories that maybe don't have a very high level of clearance in terms of analytical or clinical sensitivity and specificity.
Where do you place post-infectious encephalitis in this new paradigm of autoimmune encephalitis?
Well, I think it's kind of, I think it's a real thing. I don't know for sure that all of these are kind of classically autoimmune. We may actually learn quite a lot from COVID-19, because there are probably going to be a lot of post-infectious encephalitis cases there. But what typically is the case actually with most post-infectious inflammatory brain problems is we don't find antibodies. So there may be other factors at play here. There may be that the patient has had kind of a general cytokine storm systemically that has in some way gotten across the blood-brain barrier or something and caused disruption to the brain networks for a period of time, or caused inflammation, secondary inflammation, or maybe even brain ischemia or something like that. So I think that the HSV NMDA thing is kind of fairly clean. I'm not sure I fully understand all the mechanism of that. It's obviously kind of a different mechanism to paraneoplastic, but I think that would be something you could say post-infectious autoimmune. But maybe a lot of the other things that we're seeing are more, at this point, post-infectious inflammatory, and we just don't have a specific, well-understood mechanism, and it may not be, antibody-mediated.
Thank you, Dr. McEwen.
Thank you.
Thank you all for participating in today's specialty testing webinar. If you have any additional questions, please indicate them on the evaluation that will be forwarded to you shortly. Note, laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Also, there will be another neurology specialty webinar on June 24th from 1 to 2 p.m. on the role of CSF in Alzheimer's disease. Thank you again for joining us today.